Ladies and gentlemen, welcome to today's lecture on the topic of tracheoesophageal fistula, TEF. In this extensive script, we will delve into the various aspects of TEF, starting from its embryology and classification to the clinical presentation, diagnosis, and treatment options. We will also explore potential complications, long-term outcomes, and discuss the multidisciplinary approach required for managing TEF patients. Additionally, we will touch upon genetic counseling and the latest advancements in TEF management and surgical techniques. So without further ado, let's begin our journey into the intricate world of TEF. During embryonic development, the trachea and esophagus arise from the primitive foregut. Anomalies in their separation can lead to the formation of tracheoesophageal fistulas. Understanding the normal embryological processes is crucial for comprehending the malformations associated with TEF. The intricate interactions between the foregut, trachea, and esophagus will be discussed in detail, shedding light on the origins of TEF. TEF can be classified into different types based on their anatomical location and association with other malformations. Proximal and distal TEFs are the major subtypes, each presenting unique challenges in diagnosis and management. Additionally, TEF can occur in isolation or be accompanied by other congenital abnormalities. Studying these classifications will aid in understanding the clinical variations and tailoring individualized treatment strategies. The pathophysiology of TEF involves disruptions during embryonic development. Various theories highlight the mechanisms behind the formation of TEF, including the arrest theory, failure of tracheoesophageal fold fusion, and the faulty recanalization hypothesis. Understanding these pathophysiological aspects provides a foundation for the diagnosis, management, and prevention of TEF. Recognition of the clinical signs and symptoms associated with TEF is crucial for early diagnosis and prompt management. The presentation can vary depending on the type and severity of the fistula. The script will detail the typical clinical manifestations, including respiratory distress, feeding difficulties, choking, and recurrent respiratory tract infections. Furthermore, the physical examination findings that aid in the diagnosis of TEF will be thoroughly discussed. Accurate diagnosis of TEF requires the utilization of appropriate diagnostic modalities. Contrast esophagography, also known as a contrast swallow study, and bronchoscopy play pivotal roles in confirming the presence and identifying the location of the fistula. This topic will cover the procedural details, indications, limitations, and interpretation of these diagnostic tests. While TEF is a distinctive anomaly, it is vital to consider other congenital malformations that may present similarly or coexist. Differential diagnosis involves ruling out conditions such as esophageal atresia, tracheomalacia, gastroesophageal reflux disease, and other associated anomalies. Distinguishing between these conditions is essential to provide appropriate management strategies and ensure better patient outcomes. The treatment of TEF depends on the type, associated malformations, and overall patient condition. Surgical intervention is the mainstay, aiming to repair the fistula and restore normal anatomical and functional continuity. Preoperative management, including respiratory support, nutritional interventions, and infection control, significantly impacts surgical success. This section will provide an in-depth analysis of both surgical and preoperative strategies. TEF repair surgeries are not without complications. Anastomotic leaks and strictures are among the most common postoperative complications. Understanding the risk factors, prevention strategies, and management options for these complications is crucial for ensuring optimal outcomes. The script will delve into the intricacies of managing these complications, including the role of endoscopic interventions, balloon dilatation, and other modalities. Assessing the long-term outcomes and prognosis of individuals who have undergone TEF repair is essential for monitoring the success of surgical interventions and guiding further management. Evaluating factors such as respiratory function, swallowing ability, growth, and development helps gauge the overall quality of life and identifies potential challenges that may arise later in life. This section will shed light on the prognosis and outcomes of TEF patients. Managing TEF necessitates a coordinated effort among various healthcare professionals. The multidisciplinary approach involves the collaboration of ENT surgeons, pediatricians, anesthesiologists, and neonatologists. Coordination between these specialties ensures comprehensive care, rapid diagnosis, appropriate surgical intervention, and optimum postoperative management. This topic will highlight the roles and responsibilities of each team member in the TEF management process. TEF can have a genetic basis, and genetic counseling plays a crucial role in understanding the familial implications of this condition. Exploring the genetic aspects of TEF, including associated genetic syndromes and potential inheritance patterns, will aid in providing comprehensive healthcare services and empowering families with the necessary knowledge and support. The field of TEF management is continually evolving, with ongoing research leading to advancements in surgical techniques, diagnostic modalities, and perioperative care. This topic will provide an overview of the latest research findings, such as the introduction of minimally invasive procedures, innovative surgical approaches, and novel interventions that are improving outcomes for TEF patients. To summarize, we have covered the origins, presentation, diagnosis, treatment, complications, long-term outcomes, and multidisciplinary care of TEF. We have also discussed genetic counseling and advancements in management. Thank you for your attention.